This is LiveWell Talk on prostate cancer. I'm Dr. Dustin Arnold, Chief Medical Officer at Unity Point Health St. Luke's Hospital. According to the American Cancer Society, other than skin cancer, prostate cancer is the most common cancer in men in the United States. Return to the podcast today to discuss prostate cancer is Dr. Nick Loudas, radiation oncologist with St. Luke's Nassif Radiation Center, and Dr. Tom Richardson, urologist with Physicians Clinic of Iowa Urology. Dr. Loudas, Dr. Richardson, welcome.
Thank you.
Thank you.
I know, Tom, it's been 4 years since you've been on. It was 2000,
Correct.
Right about this time of the pandemic, or into the fall of the pandemic. Nick, I don't...
2021.
Somewhere in there, yeah, right. You hadn't been here very long.
No,
I know
it's
that
pretty
you
early.
started, but let's just start with prostate cancer. We mentioned this on previous podcasts too. It used to be a disease of old people, right? Old guys, but now, I mean, trending prior to the pandemic, and we've talked about that in other podcasts. Aggressive cancers are presenting more and more younger people: colon, breast, blood cancers, prostate cancer, and you see that. What's been your experience in your career as far as, do you see that in your practice too, that younger people are coming in with prostate cancer?
I don't know that they're necessarily coming in sooner, but they're just being detected sooner just because of I think what we do with respect to, prostate cancer screening and what the American Urologic Association, the American Cancer Society, and others have done with respect to, recommendations for prevention. That's a big debate. Is a rectal exam and a PSA sensitive in a specific way to look for it? But we know that if you live long enough as a man, you have a 60 to 70% chance of having prostate cancer, and the vast majority of those men are going to die with it, not of it. And our goal for Nick and I is to try to detect people who, if they went undetected, it would have an impact on their life expectancy, and then try to find a way to treat them in a minimally invasive, if possible, or surgery, radiation, cryotherapy, a way that can maintain people's quality of life and cure them of their cancer. I think Nick would agree with that.
You said it. I mean, there was a tendency for a while to screen less for prostate cancer, and we've seen some of the fallout from that later on down the road here. But more recently, we've gotten back to a little bit more aggressive screening in the past few years, which I think is the right thing to be doing.
I think listeners understand, as I get starting at the age of 50, I should be screened for prostate cancer. And that's easy enough. But what are some symptoms of a younger patient that should prompt them to seek medical attention?
Well, I think it's a challenge because a lot of people equate the symptoms that occur as a man ages, as their prostate becomes larger. BPH, benign prostatic hyperplasia symptoms, or bladder outlet obstructive symptoms, which can be, more frequent urination, getting up more at night, urgency, weak stream. Those two can exist in parallel. In other words, someone can have those symptoms and think that must be indicative of an underlying problem and be concerned about prostate cancer, when the two are unrelated. And I'm sure Nick would agree. Most cases, men with prostate cancer are essentially asymptomatic until it's sadly progressively very advanced. So someone who has had prostate cancer detected, very high PSA, just systemic symptoms, feeling poorly, weight loss, and some urinary symptoms. But by and large, prostate cancer that we're detecting with PSA and rectal exam is an asymptomatic problem.
Yeah, further highlights the importance of screening because many times it's asymptomatic, and there's not really a reliable way to diagnose yourself with prostate cancer based on symptoms.
And so starting at the age of 50.
Not to interrupt, but I think it would be similar like breast cancer in women. Breast cancer in women is going to be detected by a mammogram or some sort of advanced imaging, or a breast exam that feels an abnormality. Most women with breast cancer, which is also a hormonally sensitive kind of gender-specific cancer like prostate cancer, very similar. Not something that someone's going to have a symptom unless it's widely advanced. So I kind of use that as an example.
Yeah, that's a great example. So starting at the age of 50, rectal exam, PSA, every year?
There's some debate about that, and I'd let Nick chime in. If you have a family history of prostate cancer, many brothers or father on the male side of the family, those folks we would encourage earlier screening with prostate exam and PSA.
Like colon cancer is 10 years, age of 50, or 10 years
Since they're
10 years younger than the age of onset for the first degree relative. So
Yeah.
if dad was 45, I get my colon cancer screen at 35. Is there such a thing for prostate cancer?
I think if you have a very strong family history, and then nowadays with all the genetic testing that's available, we can also identify those cohorts that are actually truly at risk. But I would say if you have a strong family history, you ought to have a rectal exam at least by the age of 45 and an initial PSA. And then if that one is very low, there's some good data that would suggest you don't necessarily have to have one every year, but starting at 50, rectal exam and PSA once a year.
Now, PSA, what upper limit normal is 4.0, somewhere in there. What's the upper?
So PSA, which is an enzyme produced exclusively by the prostate gland, has always had the knock on it is that it's sensitive, but it's not specific, meaning if you have a problem, it's going to be elevated, but it can be elevated and you don't have a problem. So it used to be everything less than 4 was normal, anything greater than 4 was abnormal. Age-specific reference ranges came into play, allowing for a PSA to rise as a man ages without it being abnormal. So 40s 2.5, 50s 3.5, 60s 4.5, 70s 4.5 for 60s, 6.5 for men in their 70s. And then there's also age specific. There's free and total PSA now, which are molecular forms of PSA. There's a 4K score. There's other blood tests that can discern a PSA elevation that's for some other reason.
Okay, what listeners, I want to get across for listeners, because here's what they sometimes hear, and let's explain it, or explain the best you can, either one of you. So PSA of 4, and then the next week it's 12, or PSA of 4 and the next week it's 7. Does that make a difference? Somebody's creatinine or potassium, let's say, or goes from creatinine goes from 1 to 3. That's huge, right? Where PSA is measured, I've seen it in the hundreds on some patients. Yeah. So how try to explain to patients what that unspecific aspect of the PSA. It's more directional than diagnostic at some point.
And at the risk of I'm the person that sees those folks, right? Nick is seeing them once they've been diagnosed with prostate cancer. So the AUA basically says now, if I see a gentleman who comes in and whose PSA is for the first time, let's say last year it was 2.5 and he's 58 years old. This year it's 9. They strongly recommend against anything other than repeating that after a period of time. And there are some things you can say: abstain from ejaculation for 72 hours. There's some statistics or some studies that would suggest that impacts it. Try to control for any variables that might have come into play. There are some people who think bicycling long periods of time on a tractor, there might be some other things, but the first time someone comes in with one PSA that's elevated, if their rectal exam is normal, most people would say, repeat that after a certain period of time. Do not immediately do a biopsy on that patient.
Okay. All right.
So
I think patients worry, but because they don't understand milligrams per deciliter,
right,
et cetera, and so they worry.
Yeah. It can be high and there can be no problem.
Okay.
But it can also,
So we know that a risk factor is male. You've already mentioned that. What are some other risk factors for prostate cancer?
Obviously, family history is a big one.
Age is the biggest one. Yeah. It's fundamentally a disease.
African Americans, I believe that's what we were told in medical school. Is that still true?
You know what? African American, the big issue there is they typically present with prostate cancers that are higher grade and more advanced stage. It's not so much that it is a risk factor, but it's also a risk factor for presenting, kind of further along the continuum than the Caucasian cohort. And then certain ethnicities are at lower risk and higher risk. I think people in Asian population, it's not as common. So, but age is pretty much, and family history are the two that when we're asking someone who comes in with an elevated PSA, those are the two that we typically ask.
Okay. All right.
Yeah. There's a few softer risk factors too. There's a few dietary linkages to high-fat diets and red meat and things like that are not nearly as well established. I believe there's also a linkage to some other environmental exposures, like Agent Orange is a fairly major one in the VA population.
So once a man's diagnosed with prostate cancer, what are the treatment options that are best for them? I mean, I think, chemotherapy, radiation, brachytherapy. I know that's your expertise, Dr. Richardson. Surgery, waiting. What? Walk us through what happens. How do they go from Dr. Richardson to Dr. Loudas?
So I think the first thing is they get a biopsy, and that's an office-based procedure typically, and takes about 20 minutes. It's reasonably safe. There's a small risk of a little bit of blood in the urine or some blood with a bowel movement, and a low risk of an infection that would require anything more than some oral antibiotics. When they come back, we go over the biopsy, and really the biopsy is that's really the key piece. And there's something called the Gleason grading system, where under a microscope they look at the cellular pattern and grade that from a scale from 1 to 5. 1s are rare, 2s are less rare, 3s, 4s, and 5s are more common, and the higher that number, the more aggressive, the more within the context of prostate cancer that tends to not be aggressive, but that really matters. And they look at the most prominent pattern, the second most prominent pattern, add those two numbers together to get a score. So your Gleason score could be anywhere from a 1 + 1 = 2 to a 5 + 5 = 10. Truth be told, most people are in the 5, 6, and 7 pattern, but there's some features on the biopsy too that we look for, certain things that increase your risk, perineural invasion, lymphovascular invasion. There's cribriform pattern. It's all very complicated, but those Gleason scores are now being broken down into what are called grade groups, with grade group 1 being low grade, favorable risk, where those people could be watched. Then grade groups 7, either 4 + 3 or 3 + 4, that becomes kind of either favorable or unfavorable intermediate risk prostate cancer. That's grade groups 2 and grade group 3, and grade group 4 and 5 are anything that have that pattern 4 and 5 or in a combination. And that really matters, because how they respond is very dependent upon that, and Nick can expand on that further, particularly from a radiation side of things. But obviously, surgical removal of the prostate robotically through a minimally invasive approach that, we have folks in our group now that are doing single port extraperitoneal prostatectomies where the patients almost can go home the same day. That's one treatment option. There's 3 forms of radiation, but traditionally there's radiation either delivered from the outside in, and that's Dr. Loudas's specialty. There's brachytherapy, where the seeds are placed into the prostate, work from the inside out. We do that together. Yeah. There's cryoablation, which is freezing the prostate. There's a few other things that we don't do here that are less mainstream. Proton beam therapy is being one of those, and another called high intensity focused ultrasound, or HIFU. That's very new. And most importantly, there are some men who have very low risk grade group 1 prostate cancer, low volume. Active surveillance is an option for them, which means simply PSA and rectal examination intermittently with a repeat biopsy or an MRI. And MRI has a very large role now in the staging as well as the management of prostate cancer.
Interesting.
Yeah, I think the overall theme is prostate cancer is really kind of a diverse collection of similar diseases, basically. A lot of people come to me and they say, well, I have a friend who had prostate cancer, they did this. I have to tell them, well, that's not appropriate for your risk group of prostate cancer. So it really depends on the specific details of your disease to determine what treatment to be eligible for. So it can range anywhere from no treatment, active surveillance for low risk prostate cancers, to prostatectomy can be used for the majority of prostate cancers. Sometimes we start to lean away from that for more advanced prostate cancers because there's a high risk they might need additional treatment. And then radiation, there's a wide range of what I do with that as well. Sometimes it's appropriate just to treat the prostate gland without any hormone therapy. Oftentimes people need short-term or long-term hormone therapy paired with that. Sometimes we treat lymph nodes, and even nowadays, there's a role for radiation at times in patients who have limited metastatic disease as well. So it's constantly evolving. I'd say the really important thing is to pin down exactly the details of your disease with whoever the treating physician is going to be to make sure that you get the right treatment. So brachytherapy is one that we do a lot of. We have to be pretty selective about who's eligible for that because it depends on a lot of things, baseline symptoms, stage of the disease, and so forth. So I like to think of it as kind of a large collection of similar diseases, but they're distinct in terms of their behaviors and the appropriate treatments for them.
That's a nice overview.
And I would echo what Nick says. A lot of times these patients come in and they'll say, well, my neighbor down the street, you cannot, I tell my patients, not because we're trying to hide anything, I'm like, this is the time for you to circle the wagons and trust the people that you trust. The disease is just much different. It's not like I have diverticular disease and I need my colon resected. It's very targeted, and it's becoming even more targeted in the sense that, like he said, sometimes if in advanced disease, the new paradigm is really folks who we think have a really good chance of having some microscopic extracapsular extension or a possibility of, microscopic lymph node involvement, even though we've done everything we can to prove that. Those folks are not going to benefit from a surgical removal of the prostate and would benefit more from neoadjuvant hormonal therapy, which is a way to drop the testosterone to a low level, another oral medication, which has a secondary benefit for a period of time before, during, and 2 years after. So every case is very unique. And that's the beauty of what we have here in Cedar Rapids is we have the resources to individualize that treatment. And so that not everyone, you don't just categorize everyone into 2 categories. We have the ability to do lots of very unique sort of things that are, I would say, specific to each person's diagnosis.
Maybe I should do a podcast on what my neighbor said to do.
Yeah.
We could just have various responses to that. What can I do to minimize my risk? I can't change my sex.
I think it's more... there's more of a focus on how do you reduce your risk if you get prostate cancer as opposed to preventing it in the first place. So early detection is probably the key.
When you have more choices. Yeah. I say to my patients all the time, it's important for us to not make the treatment worse than the disease. So in some men, who have very low risk grade group 1 prostate cancer, I've got patients in my practice now who I've been following for 7 or 8 years, and their PSA hasn't changed. Their biopsies are the same, and their MRI. So we've bought them 7 years of quality of life without jeopardizing or compromising their life expectancy if we ultimately do decide. We're not missing a window of opportunity to treat them.
Right. That's, when you have elderly patients or complex patients, you have windows of opportunity in their care, and you don't want to miss those windows.
And it's important to make the distinction. Watchful waiting is in someone who has potentially clinically significant prostate cancer, but they also have COPD, coronary artery disease, and they're diabetic. And we think that their life expectancy is such that it's safe to watch their prostate cancer. That's very different than active surveillance. Active surveillance is we really think that Gleason 3 + 3 = 6 prostate cancer. I think in the future we're going to decide that it really doesn't behave like a cancer, meaning it doesn't have the metastatic potential that those higher Gleason grades do. And there's some studies that would suggest that. And so active surveillance and watchful waiting is not an interchangeable term. They're different, and the intent of both of those is different. If you do watchful waiting, or if you do active surveillance in a young guy, and 10, 12 years later, then maybe they've got some other comorbidities, you've essentially eliminated the need to do something more aggressive that never was going to impact their life expectancy.
That's at the end of the day, that's patient-centric care is what we want everyone to have.
Yeah.
I know you both good guys and you're in healthcare to help patients, but why'd you choose radiation?
Well, I don't know if it has much to do with prostate cancer specifically. I like the variety, and so I enjoy treating prostate cancer. It's probably my favorite body site to treat and sort of an interest of mine. But I like the fact that I need to be proficient in essentially any cancer that is treated with radiation. I have a lot of variety throughout my day too. So I do some stuff in the OR every so often. I do a lot of treatment planning. I see clinic patients. I get bored if I do too much of one thing. So I like having all these different sort of disparate responsibilities that this specialty allows for. So, and the main reason was I enjoyed it when I I explored it during medical school. So
Yeah. Tom, why urology?
Truthfully, I went to Indiana University for medical school, and they had a very, very good urology residency program there. And there was a very famous guy by the name of John Donahue, who actually, he and Larry Einhorn were the ones who basically sort of pioneered the surgical and chemotherapeutic management of testicular cancer. Popularly, Lance Armstrong, they cared for him. But the urologists were just all seemed to be very content and good guys. I also like the fact that in a clinic day, I can see a 2-week-old baby and I can see a 99-year-old
Yeah,
male
a lot of variety there.
in the same day. And urology is kind of a medical surgical specialty in the sense that we have recurrent patients who come back to see us for sort of chronic problems, that it's not just we fix the problem and never see them again. I like the fact that it's not only a surgical field that requires, technical skills, but, we do a lot of reading of our own images. It's just I think an intellectually demanding field.
Well, you both do it well. Dr. Loudas, Dr. Richardson, thank you again for joining me today and educating our listeners about prostate cancer and treatment options. To learn more information about cancer care services at Nassif Community Cancer Center, visit communitycancercenter.org. That's visit communitycancercenter.org. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.